We are now discussing subclavian steal syndrome, a high-yield vascular condition for the MRCP examination. This syndrome occurs when there is significant narrowing or occlusion of the subclavian artery before the origin of the vertebral artery. Because of this proximal obstruction, blood can no longer travel normally to the arm. So the body compensates by reversing the flow in the vertebral artery. Instead of moving towards the brain, the blood is pulled down the vertebral artery to supply the arm. In simple terms, the arm steals blood from the posterior cerebral circulation, and this becomes more obvious during arm exercise when the demand increases. This reduction in blood supply to the vertebrobasilar territory produces neurological symptoms. The condition is more common on the left side because the left subclavian artery arises directly from the aortic arch, which exposes it to higher flow turbulence and increases the risk of atherosclerosis. Causes. The most common cause is atherosclerosis. Other causes include Takayasu arteritis, thoracic outlet syndrome, trauma, radiation, or previous surgery affecting the vessel. Clinical features. There are two groups of features, and the exam often mixes them in the same vignette. First, neurological features due to vertebrobasilar insufficiency, dizziness or vertigo, syncope or near syncope, visual disturbance such as blurred vision or double vision, ataxia or an unsteady gait. Second, upper limb ischemic features, arm fatigue or weakness, especially during exertion, arm pain or claudication. On examination, the radial pulse is weaker or absent on the affected side. There is a blood pressure difference between the two arms of more than 15 millimeters of mercury, with the lower pressure in the affected arm. This inter-arm blood pressure difference is a classic exam clue. Diagnosis. Always begin by measuring blood pressure in both arms. The first-line investigation is Doppler ultrasound, which shows reversed flow in the vertebral artery. For confirmation and anatomical detail, use CT angiography or MR angiography. The gold standard is conventional angiography, which both confirms the diagnosis and helps plan intervention. Management. Start with risk factor modification. Control hypertension. Treat dyslipidemia. Optimize diabetes management. Encourage smoking cessation. Give antiplatelet therapy, such as aspirin, to reduce thrombotic risk. If the stenosis is significant or the patient is symptomatic, move to revascularization. The usual first option is percutaneous angioplasty with stenting. For complex disease, consider surgical bypass or subclavian endarterectomy. MRCP exam key concept. When a patient has vertigo, diplopia, or drop attacks, arm claudication with exertion, and a systolic blood pressure difference between the arms greater than 15 millimeters of mercury, think immediately of subclavian steal syndrome.